Hello everyone, my name is Başak Ceydan Meço. I'm from Ankara, Turkey, and today I will be talking with you about inhalation anesthetics. We know that inhalation anesthetics is a quite important topic in several exams, so I just wanted to cover briefly the history of inhalation anesthetics and then talk about, of course, the very important topics as pharmacokinetics and pharmacodynamics, and then we can discuss some of the agents that we are using or we should know. So to start with the history of inhalation anesthetics starts in the 1840s with nitrous oxide. But each time they were discovering a new agent, there were problems coming with that, as some of them were flammable, and they tried to find a less flammable one. And then we also had some agents with hepatotoxicity, several toxicity, some arrhythmogenic effects. So every time the scientists were trying to find a less toxic and easier to use agent, which was then defined as agents having some pharmacokinetic advantages and also minimal side effects and risks. Of course, cost was an issue, and we arrived in our years with sevoflurane, desflurane, isoflurane, quite new agents. So what is pharmacokinetic? We know that pharmacokinetics means what the body does to the agent that we are giving. These definitions are quite important in several exams. So when we are talking about pharmacokinetics, we need to talk about the absorption of the drug, the uptake of the drug. And for inhalation anesthetics, it's the uptake from the alveoli to the pulmonary capillary and then at the end to the brain, of course. Then we need to talk about the distribution in the body, because our aim is to bring this agent to the brain, but then we know that it's also distributed in the total body. Of course, metabolism is an important topic, and also the elimination is quite important for us clinically, because with the elimination, we will have the recovery of the patient from general anesthesia. So if we talk about the first step of the pharmacokinetics, we know that for inhalational agents, we are talking about partial pressures, and there is a gradient of partial pressure starting from the anesthesia machine, going through the breathing circuit to the lungs, to the blood, and at the end to the brain, which is the site of action for us. This agent needs to be propelled from the machine till the capillaries to have the effect on the brain. So during this period, the brain equilibrates with the partial pressure of the inhalation anesthetics, which is in the blood, and this blood already equilibrates with the lung. So it's important to know that we have different parts, different organs in our body that we need to equilibrate between these different phases. And what we are equilibrating is the partial pressure. It's not the concentration, but the partial pressure of the inhalation anesthetics. When we are talking about inhalation anesthetics, we need to focus on the partial pressure of these agents. So what is this partial pressure? This partial pressure is actually in the alveoli, and this partial pressure that we will be giving in the alveoli will eventually gives us a partial pressure in the brain, and this will be the effect of our agents. And to calculate, to assess this partial pressure, of course, we know that we have an input. Some agents will come to this alveoli, and then some output, some loss, which will be the drug that is uptake from the alveoli. So when we are talking about input, we need to talk about the delivery of the anesthetics, which is the inhaled partial pressure. And then we also need to talk about the alveolar ventilation, because we know that in this alveoli, we have a ventilation, which will bring out and the agent, in and out the agent. Also, the characteristics of the breathing system, as I showed previously, that everything starts from the anesthesia machine. So the characteristics of the breathing system is also quite important to assess, to qualify the input of our agent. What about the uptake? What about the loss of the agent? Here, the solubility of the anesthetic agent in tissues is important, because we will be losing this agent from the alveoli, not on the exterior part by expiration, but also in the tissues by the solubility. Of course, to assess this solubility, we need to have the blood coming to the alveoli and going from the alveoli, which can be defined as the alveolar blood flow, or in a more general way, as a cardiac output. And again, we have a difference between the alveoli and the venous system, because we know that once the agent is in the blood, this agent will go into brain, but in all other organ tissues, and will be absorbed in these tissues. So the blood coming from these tissues will go back to the lungs and will again be available to uptake some agents. So if an agent is highly soluble in tissues, this venous blood will be emptied in a way from the agent and will be available to uptake new agents. These definitions, these physiological parameters are quite important and are highly asked in questions. So I'm trying to simplify the scenario for you to understand easily and not to forget. So when we are talking about inhaled partial pressure, it's very important to talk about the concentration effects. This is a regular question in all the EDAI questions. So if you have a high partial inhaled partial pressure in your alveoli, this will in a point offset the effect of the uptake, because you will always regenerate new agents with this inhaled partial pressure. And then, of course, this will speed the rate of the increase in the alveolar partial pressure, which will again then lead to the induction rate, which will increase. So it's quite important to increase the inhalation agent, the agent that you have in the alveolus, to have a steady state high concentration, which will be equalized with blood. So let's give an example to that. If we have a 50% uptake of an agent from the lungs, what is the concentration effects? Let's assume that we have 20% concentration of an inhaled agent. And of course, this will be in the other gases. So let's talk as parts. If we have 20 parts of the selected agent in the 100% of gases, which is made of oxygen air, and half of it is absorbed, is uptaked from the alveoli. So at the end, in the alveoli, we will have 10 parts of our agents, and the overall gas will be 90 parts. So when we divide 10 to 90, we will have a percentage of 11% of inhaled agent in the alveoli. Now, if we increase our anesthetic agents to 80%, if we increase by 4 the concentration, the partial pressure of our inhaled anesthetics in this mixture, again, half of it will be uptaked, and we will have 40 parts of agent in 60 parts of gas. And then this will give us a 67% of concentration. So when we are multiplying by 4 the concentration, the inhaled partial pressure of our agent, we will have a 6 times increase in the alveolar concentration. So this is how we should be explaining the concentration effects. When you explain a question in an exam, it's always easier to use an example and to explain with your examples. Again, what is the second gas effect? The second gas effect is the concentration effect of one gas upon another one, which means that if we are mixing now 2 agents, like nitrous oxide with another agent with a second gas, which can be sevoflurane, desflurane, as you wish, then the absorption of this first gas will lead to an increase in the concentration of this second gas. And this concentration effect is more significant with nitrous oxide, because we can use nitrous oxide in higher concentrations. Again, we have an example here with a mixture of 80% of nitrous oxide with 1% of the second gas, and then of course 19% would be the oxygen. So once half of it is uptake, then we will again, the same calculation goes here too. I won't redo it not to lose time. And then you have, of course, a higher concentration of second gas. Then here we also have new gas coming from the trachea, which is the augmentation of tracheal inflow. As there is an empty space in the alveoli, we have new flow. And this again, one more time, when you do the mathematical calculations, will increase the concentration of our inhaled partial pressure in the alveoli, which will then speed the induction, the anesthesia. So what was the second parameter? The second parameter was the alveolar ventilation. Of course, if we have a higher alveolar ventilation, this will again offset the effect of the uptake and speed the rate of increase in the alveolar partial pressure, which will again increase the induction rates. This effect is even more important when the agent is soluble. This is very logical. You can understand that if an agent is soluble, it will tend to be dissolved and uptaken. So it will be even more important to bring new agent to the system with this higher alveolar ventilation, for example, to decrease this effect of uptake and to have a quick induction. And there is also another aspect here, which is also quite frequently encountered in questions, is that the inhaled anesthetics, they do a kind of negative feedback to their effects, because each time we are giving an inhaled anesthetics to a patient, this will decrease in a dose-dependent manner the alveolar ventilation. We all know that these agents will decrease the alveolar ventilation of our patients. And by decreasing this alveolar ventilation, we will have a kind of negative effect, negative feedback, which means that the offset of uptake will be offset in a way. It won't be here anymore. So the increase in partial alveolar pressure, the rate of increase will decrease, and this will slow the rate of induction, which is a kind of protective way for our patients. What about the anesthetic breathing system? Of course, this is another topic, but briefly, we know that the characteristic of this breathing system is important. If the volume is too big, if the agent is very soluble in our breathing systems, this will logically decrease our induction rate. For the volume, we can still use high gas flow. And for the solubility, it's important to use correct material, not to prevent this solubility effect. Oh, again, what is solubility? Solubility of an inhaled anesthetic in blood and tissue is denoted as partial coefficient. It's the distribution ratio, how the agent is distributed between two phases. And when these two phases are in equilibrium, we can talk about the partial pressure is equal in both phases. And this partial coefficient, this distribution ratio, of course, reflects the relative capacity of each phases to accept the anesthetic gases, and this is temperature dependent, such that the solubility of a gas in a liquid is decreased when the temperature of the liquid is increased. So here you can see the different solubility blood gas partition coefficients, this solubility coefficient, and if an agent is highly soluble, you will eventually you can comment that the induction rate will be slower, because the agent will come to the alveoli and immediately will be dissolved in blood, and the equilibrium won't be achieved. So it will decrease our induction rate. And here we have some examples. If the patient had a very heavy, if the patient is hyperlipemic, the blood has much of lipids, as we know that the solubility in lipid is even higher, so the induction will be even slower. And in contrary, if the patient is anemic, then the induction will be higher, because the solubility in anemic blood will be lower. So this graph is really an important one. It summarizes you all that we said since now, that the solubility is related to the increase in partial pressure in the alveoli divided by the partial pressure of inspirium. This is very important. Sometimes we ask you to draw this graph, or sometimes we ask you to discuss about this graph. So I think that it's important to state it here. What about the cardiac output? If we increase the cardiac output, logically, and as I said, I'm saying since the beginning of my talk, this cardiac output will increase the uptake and then decrease the induction rate of our agent. Again, this effect is more important in soluble ones and less important in insoluble ones. And if we have a patient with low cardiac output, these patients are prone to be overdosed with these soluble agents. Here we have another effect, which is not the negative feedback, but now a positive feedback, because once we give the anesthetic agents, which depresses the cardiac output, we know that the volatile anesthetized mostly depress the cardiac output, then we will have a kind of positive feedback, because then the blood which has anesthesia won't go away from this alveoli, and this will give us a positive feedback to our induction, in contrast to the negative feedback that we see on our patients. Be careful, this negative feedback is applicable only on spontaneous breathing patient. If the patient is mechanically ventilated, you will offset, of course, this negative feedback in your patients. Another parameter will be the alveolar venous partial pressure differences. So this I stated previously. We know that once the agent is in the alveoli, it goes to the venous blood that comes to the lungs. And then this blood will go through the body. And if a tissue absorbs, if the agent is highly soluble in other tissues, like fat tissue, muscle tissue, liver, brain, then we will have the blood which go back to the lungs will have low concentration, low partial pressure. So it's in parallel. All these, the partition coefficient in the lung will parallel the partition coefficient in the tissue. So these are all in parallel, and this will lead us to a decreased rate or increased rate depending of the coefficient. Again, here the factor that determines the fraction of anesthetics removed from the blood to the tissue to send back this cleaned blood, if I may say, again to the lungs, depends on tissue solubility, tissue blood flow, and also arterial to tissue partial pressure differences. So what we have in the lung side, we have the same thing in the tissue side, which have the similar effects. And here you can see different tissue groups that are, again, this graph is again a high-rated question in our exams, that we know that at first all the agents go to the vessel-rich groups, and then once these, after a period of time, our medication goes to the muscle group, which is a big tissue with and fat group, which is again a big tissue with less vessels. So it's important to see how the agents are distributed and then how the agents are redistributed from these tissues. If we need to talk now about the elimination of our drugs, which means the recovery of our patient from general anesthesia, of course the biotransformation, the transcutaneous loss are here, but the most important function, the most important parameter in the elimination is the exhalation of our inhalational anesthetics from the lungs. And of course, all the factors that speed induction will again speed the recovery, because as I said, all these functions are in a way similar, like symmetrical. So if we have it's important to have high fresh gas flow, low anesthetic circuit, low absorption by the circuit. All that we talk for induction, we can talk for recovery. Again, the solubility, decreased solubility is important. High cerebral blood flow is important to take out the agent from the brain, and increased ventilation again will be important. We have something different in the recovery, which is that the rate of decrease of the brain will be reflected by the rate of decrease of the alveolus, of course. But and we know that the wash out of these agents from the brain is quite rapid, because these agents are not highly soluble in brain, and the cardiac output mainly goes to the brain. So the mechanism, the physiology is adapted to clean the brain as soon as possible. But there's another parameter here in the recovery. As we talk about the tissues, some tissues don't saturate, they don't come to their equilibrium point even at the end of the anesthesia maintenance. So during this recovery period, when we conclude our anesthesia maintenance, still some tissues are uptaking anesthesia from blood. So not only the extraction with the lungs, but this uptake from not saturated tissue will increase the rate of recovery. So the rate of recovery will be faster than the induction because of these non-saturated tissues, which will again uptake our agents. So this was the pharmacokinetic. We talked about what our body does to the drug. Now it's important to look from the other side, from the pharmacodynamic side, and to talk about what the drug will do to us. And here we have the minimum alveolar concentration, which is a quite important definition. Of course, there are some parameters, some factors that will alter this minimum alveolar concentration. And very briefly, it's important to talk about the mechanism of action of inhalation anesthetics. So what is the minimum alveolar concentration? It has a very clear definition. Minimum alveolar concentration is the concentration that prevents the skeletal muscles movements in response to a standard surgical painful stimulus in 50% of our patients. Actually, it is the ED50 for another agent. We know that this effect is achieved with the effect of our inhalation agents on the spinal cord and lessly on the cortex. So the minimum alveolar concentration is mainly from the spinal cord because there is a movement. And also 1.3 Mach will prevent almost all our patients' movements, which is quite important for a surgical procedure. And we can define the minimum alveolar concentration as a measure of potency. A patient with high minimum alveolar concentration, which needs higher concentrations to achieve this surgical situation, surgical accuracy, and which means that the potency of this agent will be low. If we have a high Mach, if we need high concentration, of course, the potency of this drug will be low. These are the different minimum alveolar concentrations of different agents. Again, here you can see that if the Mach value of an agent is high, the potency will be low. Of course, these are important data to be known by you. Again, with Mach, we have different Machs. We have derivatives. They are not always very used, but they are important for us to see the different clinical steps of our anesthetic management. For example, when we are talking about Mach unaware, it is the Mach that we have the loss of consciousness. This is during induction, which means that half of our patients remain responsive to verbal commands, but they are losing their consciousness. And then we have the opposite of this, which is the Mach aware, and here the 50% of our patients can't answer, their voluntary response are suppressed, but this is again during the emergence of anesthesia, and we know that the Mach awake is lower than Mach unawake. Again, here we have the Mach bar, which means that even the autonomic response of our patients, half of our patients, is lost, which means that the effect is at the level of the brainstem, and again we may have a Mach amnesia. This means that the patients are not remembering. These are the lower Machs because the patients are more awake, but they don't remember. These Machs are not that much used in the clinical practice, but it's important to know them. Here you can see that, as I previously stated, that the Mach unawake, the Mach that we achieve during the induction phase before achieving a Mach of loss of movement, is higher than the Mach awake, which is during emergence. So what parameters would affect the Mach of our patients? First of all, it's important to know that the Mach value is additive. So it's very important. If you give half Mach of one agent and half Mach of the other agent, the overall result will be 1 Mach. So will be 50% of our patients won't be moving. Again, the Mach values are quite consistent between individuals. This gives us an ease to use this Mach parameter. But of course, as any other parameters, Mach values also are affected by different physiological variables. For example, I gave here 2 examples, which is that with aging, you know that aging is also very popular because the world is aging, so it's also popular in our questions. With aging, the Mach value decreases by 6% for each decade. Again, during pregnancy, the Mach value decreases even during the early postpartum period by 30%. There are many other parameters like that which increases or decreases Mach that should be known by you, as hyperthermia will increase the Mach value, hypernatremia will again increase, and there are some parameters that won't change, like gender, like anesthetic metabolism, etc., etc. It's important to have some examples to know for what is increasing MAC, what is decreasing MAC. Again, this mechanism of action of inhaled anesthetics is a big topic because it's not perfectly defined, if I may say. We first have a lipid bilayer membrane theory, which was stated as these agents are affecting this lipid bilayer membrane and leading the cell to dysfunction in some point. But now we know that the action is more in the functional protein sites as ion channels, NMDA receptors, or GABA receptors. In several points, several cellular sub-elements, the inhalational agents have effects. But also they have their effects in different anatomical side of our central nervous system. As I said previously, we have some effect in spinal cord, but also we have effects on reticular activating system or cortex of a patient. It is important to know that this effect is not only in one point, but we have several mechanisms in several different sites of actions. Now, if we need to talk about our mostly known agents, I just prepared some slides, one slide per agent, just to briefly overall describes you. But what is important is that at the end, there is a table that you can also find in your books that summarize, because mainly all agents have quite similar effects. And when it is asked you to describe what are inhaled anesthetics doing to the body, it is very important to explain to your jury, to your examiner, in a very systematic and algorithmic way. So it's important to start from what is this agent, what are the main effects in different organ systems, what are the side effects, what are the contraindications. So just to give you an example, I prepared these slides, which to show you that it's important to explain different aspects in an algorithmic step-by-step way. So if we talk with the first agent, which is the nitrous oxide, we know that it's colorless, it's odorless, it's not explosive, it's a gas in room temperature, and it is said that it acts on NMDA receptors. So what are the main effects? We know that all agents have several similar effects, as they most of them, they depress myocardium, but for nitrous oxide, we have some sympathetic stimulation. Also, nitrous oxide increases the pulmonary vascular resistance and the respiratory rate, but it decreases the tidal volume and depresses all these hypoxic drive, the hypercardic drive, which means that for the respiratory system, most of the inhaled agents are depressants. If we look to the central nervous system, we can say that almost all our inhalation agents will be increasing the cerebral blood flow, cerebral blood volume, the pressure, so they are not quite good agents for intracranial pathology patients. And for nitrous oxide, we know that it also increases the postoperative nausea and vomiting, which is quite important, and we all know that it's less and less used. The good part of nitrous oxide is that it has some analgesic effects and no muscle relaxation. Of course, these are good questions to ask. Nitrous oxides has an inhibition effect on vitamin B12 dependent enzymes. So myelin formation, DNA synthesis are disturbed, especially in long-term usage, which will give us some bone marrow depression and peripheral neuropathies. Also, nitrous oxide is teratogenic. It's very important to know this effect of nitrous oxide. When it is contraindicated, in scenarios that the patient has some air cavities, if I have to generalize this contraindication, because we know that nitrous oxide is highly soluble compared to nitrogen, so it tends to go to the air cavities and to increase their volume. So if you have a pneumothorax or air embolism or intestinal obstruction, you should not be using nitrous oxide. Let's go to halothane. I know that it's not used in many centers, but still used in some others. And when I'm talking about that, in all exams, some candidates are asked about medications or methods that they don't use, it's important to have an idea and to be able to discuss and to comment on these questions if you really don't know what they are. So halothane is a halogenated alkane which is non-explosive. Again, as I said, it will depress the cardiac system. And something special to halothane is that it sensitizes the heart for the arrhythmogenic effects of epinephrine, which is quite important. You shouldn't be using altogether these two agents. And it depresses the respiratory system in the overall, as depressing the hypoxic drive, increasing the apneic threshold. So this is important during the emergence. Your patients may have some respiratory problems. Halothane is a potent bronchodilator, and again, it increases all the cerebral blood flow, volume, and intracranial pressure. Halothane potentiates NMD, non-depolarizing muscle relaxants, but it may trigger malignant hyperthermia, which is a very loved question by all the examiners. Also, there's a halothane hepatitis, which is not a toxic hepatitis, but mainly an immune hepatitis, and it happens after recurrent usage of halothane. And when shouldn't we be using halothane? Of course, if you have a liver dysfunction, if you have an intracranial mass lesion, or as halothane is sensitized heart to the arrhythmogenic effect of epinephrine, if you have a pheochromatosoma patient, and again, as halothane is depressing the cardiovascular system, if you have a hypovolemic patient, you shouldn't be using halothane. Let's go to enflurane. Enflurane exists in some places and doesn't exist in some others, but there is an important parameter between all these other similar parameters, is that as halothane is decreasing the seizure threshold, the decrease of the threshold for seizure can be a complication, but also can be something that we desire if we are wanting to use it for electroconvulsive therapy. So this is the main difference of enflurane. And of course, enflurane is a nephrotoxic. That's why it's not frequently used. Let's go now to isoflurane. Isoflurane is an old agent now, and it's pungent. It has a bad smell, so it shouldn't be used as an induction agent or as an inhalational induction agent. Again, it depresses the cardiovascular system, and there is also an effect that used to be asked, but I don't think that it's frequent nowadays, the coronary steal syndrome, that as isoflurane dilates the coronary artery, it mostly dilates the good coronary, the already good functioning coronary artery, which then even steal more blood from the injured coronary artery. So it was an important topic, but not talked that much in our days. Again, it decreases the ventilatory parameters. It's again a bronchodilator. I won't be talking about the cerebrovascular effects, and the malignant hyperthermia also is a risk factor for isoflurane. As all the other ones, it's contraindicated in hypovolemic patient. Desflurane, we can say that it's newer than the other ones. Something specific to desflurane is that the desflurane boils at room temperature, so it has a special vaporizer that is sometimes asked the mechanisms of vapor. I didn't detail it here because there are other topics related to the anesthesia machines and all these gears, but it's important to know that desflurane needs energy because otherwise it will boil in room temperature. Again, we have the exactly similar cardiac depressant effects, cerebrovascular effects. One important parameter for desflurane is that desflurane has a very low blood and tissue solubility, and which gives us a very rapid induction and a very rapid emergence. It's something that we want. So this is the good. It's a good parameter for desflurane. And but the only problem is desflurane is airway irritant. So if you use it in a non-sleeping patient with the respiration, they will have laryngeal spasm. They won't be breathing. Desflurane is not a good candidate for an inhalational induction agent. It is again contraindicated in hypovolemic patient, in high intracranial pressure patient, and also in patient that we are expecting malignancy hyperthermia. The last agent is sevoflurane. Let's say the last and frequently used agent. This one is non-pungent. It doesn't have any smell. So it is, in contrary to desflurane, a good agent for inhalational induction, especially in pediatric patients. We know that with sevoflurane, we have again the myocardial depression, and with sevoflurane, cardiac output is not unfortunately maintained, and there's a QT prolongation that we see with sevoflurane. One good point is that autoregulation is preserved in patients with cerebrovascular disease, in contrast to all other agents. Sometimes in the part 2 questions, they ask you to compare different agents, to choose 2 agents and to compare, or to compare the stated agents. So it's important to know for this inhalational anesthetics, inhaled anesthetics, that which parameters are different or which parameters are specific to some agents compared to all these regular similar parameters. So we know that sevoflurane interacts with soda lime, but it's rarely seen. And when it interacts, it produces compound A, which is a toxic agent. Again, this agent is contraindicated in hypovolemic, malignant hyperthermia, risky, or intracranial high pressure patients. And now we have xenon, which we can say a new and a potential ideal agent, because it's inert gas, it's non-explosive, it's odorless, and for the environment, it doesn't do any environmental problems. So xenon is extremely rapidly uptake and excreted, so it's a good agent. It has good potentials. It depresses the respiration and very little effect on cardiovascular stability, which is also quite important, because from the beginning of our talk, we are saying that all inhalational agents have cardiodepressant effects. Again, this increases cerebral blood flow and intracranial pressure, but xenon, different than the others, has a neuroprotective effect through the inhibition of NMDA receptors. So again, this is a positive aspect of xenon, and environmentally, it doesn't have any side effects and low toxicity. So the only problem, of course, is the cost and the usage of xenon. It's important to know the good part of xenon, especially it is very important to know the environmental effect of all these inhalational agents, which will be even a more important topic in near future. So if we need, as I said it's important for you to summarize the common effects of these agents, and then to differentiate their specific effects and to know them. So in the overall, we know that almost all the inhaled anesthetics are depressing the cardiovascular system, depressing mostly the respiratory system, and depressing the body, which will give response to high CO2 or low oxygen levels. And in the cerebrovascular system, mainly all inhaled anesthetics are increasing cerebral blood flow, intracranial pressure. So they are not the perfect agents for cranial pathologies. The only good part is that most of them are decreasing the cerebral metabolic rate. So this is in a way a kind of protection. And most of them in different degrees are potentiating the neuromuscular blockade and have hepatotoxic, and some of them have renal toxic effects. This summary, you need to do your own summary. As I said, and I will repeat one more time, you need to know the exceptions for each agents. Again, a very important question is to define an ideal agent. If you have to define an ideal agent, it's important to define it also in a very systematic way. So when we look to the agent, it should be chemically stable. It should have a long shelf half-life. It shouldn't require additives. It shouldn't require special environments or special techniques for usage. It should be non-flammable, non-irritant. It preferably having a nice smell, easy to store, And of course, a low blood gas partition coefficient, because now we know that with low blood gas partition coefficient, we will have quick induction, and this is something that we want. Of course, it needs to be cheap. Again, we have a huge list of the actions. Of course, we don't want any adverse events as renal, hepatic, hematologic side effects, no malignant hyperthermia, no effects on uterus or on the baby. We don't want our agents to be metabolized. We want to be extracted as quick and as soon as clean as possible via the lungs. We don't want to have any organ dysfunctions, any organ side effects, no cardiac depressions, no sensitizations to catecholamines. We need good respiratory system. Preferably, they should be giving us some bronchodilation. They shouldn't have any bad effects on the intracranial pressure. They should preserve the autoregulation. They can even protect the central nervous system. But of course, we need sufficient potential analgesia, antiemetic effects, and anticonvulsant effects. Also, if they do some skeletal muscle relaxation, it's even better. And maybe the most important is to have a smooth, rapid induction with no breath holding, no laryngospasm, and also no increase in secretion. So if we have an agent with all these positive parameters, we are in a good road, and this defines the ideal agent is also a frequent question, especially for the part 2 examinations. So I want to thank you for your attention. It was a big topic. I tried to summarize. It is the first part of this talk is quite important with all these pharmacokinetic and pharmacodynamic rules, but also it's important to have a good summary of different inhaled anesthetics to be able to discuss, to compare, or to define an ideal agent. Thank you very much. What are the features of the ideal inhalation anesthetic agent? A. Smooth, rapid induction with no breath holding, laryngospasm, coughing, or increased secretions. B. Long shelf life. C. High blood gas partition coefficient. D. No decrease in organ perfusion. E. Respiratory depression.